question here, the nurse is administering enema to a client the night before bowel surgery. So a patient has a bowel surgery tomorrow, and tonight the nurse putting or insert the enema. During the inserting the enema, the client report of pain, then what we should do? So enema basically we use for constipation. But sometimes if patient need any abdominal major surgery in the GI, we have to clear the bowel first. This is the reason this patient need to the enema before the surgical night. So an enema is a method of cleaning the gastrointestinal system or colon. Usually we using an injection of fluid and loosening up the impacted bowel to help make the clear the bowel. Typically, an enema is given to help the treat the constipation, as I told you. But surgical purpose, we also use it. During the putting the enema, if your patient complain the pain, what we should do? There are 4 options. What is the answer? Number 1, have the client take slow and deep breath. Yes, breathe exercise is good, but it does not stop the pain. What are the first priority I have to do? Stop the infusion first, right? For 30 seconds, then resume at a slow rate. So when patient complain the pain, it is better to stop, wait for a minute. Then you can start very slowly. It is a good option. Tell the client that the process will not take much longer. It is not a professional answer. Withdraw the tube approximately 2 centimeters and continue the infusion. It does not make any sense as well. Number 1 is important, but number 2 is most priorities. First, I have to stop, check for a minute, then again start. So what is their explanation? To rapid infusion of enema may cause intestinal spasm. Spasm means pain that result in a feeling of fullness, cramping, or pain. If the client report any of these symptoms, the instillation should be stopped for 30 seconds and then resume at a slow rate. Slow infusion will also decrease the likelihood of premature injection of the solution, which would not allow for adequate bowel evacuation. So elimination of any impact materials, right? So if the client report the cramping of or pain during the injecting of enema, the infusion should be stopped for 30 seconds and then restart it at a slow rate. That's it. The question here, the nurse on the IV therapy team and making a round in intensive care unit. On the client with a central venous catheter, so which central line should be removed earliest to prevent infection? This question is examiner make it easy for us. Why? Because the team are given round in ICU with the client who have under the central line catheter. So there are 4 options. Which one we have to remove first, right? So if you ask me why we give the central venous catheter or why we use the central line, why the client need it, we use the central line for IV intravenous therapy or medication or chemotherapy or long-term antibiotic therapy. This is the reason we use the central line, or sometimes we use for total parenteral nutrition. The central line we can use subclavian artery, femoral artery, or peripheral insertion central line we call PICA line we use. It is very important. Every healthcare provider must know when you give the central line, the priority is to prevent infection. Every healthcare provider must know how we have to prevent infection and what are the common route of infection. There are 4 options. 1, femoral line insert in an emergency department post cardiac arrest 48 hours ago. 1 is femoral line. Internal jugular line inserted 6 days ago in the operation room. Peripheral insertion central catheter line with a lumen occluded that was placed 2 weeks ago. And subclavian line slightly redness at the suture site in intensive care unit 72 hours ago. So there are 4 types of central line. So keep in mind the femoral one is easy to put but most dangerous of infection, right? So when we put the central line, always keep in mind the way to prevent infection, like we wash the hand, then we use antiseptic solution to clean the area, right? And also changing the dressing every 30 minutes. It is good and it can prevent the infection. And when we take care of the patient who are under central line, we have to wear the masks. So when we dressing, we need to wear the masks. And I told you, femoral line is easy to insert, but more dangerous for infection. So out of 4, we must remove the femoral line first because priority is prevent infection. Let me read their explanation, what they said. In adult client, central venous catheter site in the upper body, usually we put it internal jugular or subclavian vein. And we prefer it to minimize the risks of infection. Other area like inguinal areas, femoral channel or catheter are easy to make, but easy to contamination the urine. Contaminated by the urine or feces, it is difficult to place an occlusive dressing over this area as well. The central venous catheter should be placed where aseptic technique can be applied. The site should be assessed daily for sign of infection. So what are the sign of infection? Like redness, swelling, and also the dressing getting wet or dry. We have to check it. The duration of central venous catheter placement should be placed on clinical need and judgment, right? So, and also judgment that there are no evidence of infection. So now here we said the peripheral insertion central line is called PICA line. So PICA line we can flushing with a heparin to prevent the clot or reduce the risks of clot formation. Usually PICA line we insert it into the vena cava, inferior vena cava. Another PICA line we use called port-a-cath. Port-a-cath line we use under the skin in superior vena cava. What are the education objectives and what we learn from here? The femoral central venous catheter may be placed if any kind of emergency condition, but should not remove or replace, or we should remove or should replace as soon possible due to high risks of contamination and infection. The question, healthcare provider order and magnetic resonance cholangiopancreatography. So magnetic resonance cholangiopancreatography, this is the MRI, but this MRI done in hepatobiliary system. So it is called cholangiopancreatography. By this technique, we can see the gallbladder, biliary systems, and pancreas as well. Which statement by the client would require the nurse to contact the healthcare provider? So what is the important we have to consider because of magnetic resonance cholangiopancreatography? Select all. Number 1, I am allergic to iodine and shellfish. Iodine allergy is important, but not for MRI or MRCP. Allergic to iodine is important for any CAT scan contrast or cardiac catheterization where we use the iodine. But in MRI, we do not use any iodine product. So it is not an answer. I ate lunch 2 hours ago. So if your patient have to go for magnetic resonance, they do not need to be fasting. I had my last period 6 weeks ago. So if your patient is a pregnancy, it is important to know the healthcare provider. I have a metallic rod in my leg. Maybe patient has any kind of orthopedic operation on the legs. So the metallic rod is there. It is important to know healthcare provider. I smoke cigarette. It is not a contraindication who go for MRI. So what is their explanation? Magnetic resonance cholangiography is a non-invasive diagnostic test. And by this test, we can see the biliary and hepatic duct, we call hepatobiliary system, we can see via MRI. M stands for magnetic, R for resonance, I for imaging. And MRCP, which is more MRI when more specific is hepatobiliary system, we call cholangiopancreatography. It is safer and less invasive alternate to endoscopic retrograde cholangiopancreatography that use the oral or in IV gadolinium. It is non-iodine contrast materials to determine the cause of cholecystitis, means inflammation of the gallbladder, or cholelithiasis. When the gallstone develop in the gallbladder, we call cholelithiasis or biliary obstruction. The nurse must assess for contraindication prior to the procedure, including any metallic device or any implant like pacemaker implantation. We tell our healthcare provider not to do this, or make sure my patient is not a pregnant. Pregnancy is important, or any previous allergy or reaction to gadolinium, what the agent we use for MRI here. What are the objectives? So MRCP or magnetic resonance cholangiopancreatography is used MRI technology to visualize the biliary system and hepatic duct system. Contraindication to procedure including pregnancy or presence of any metal in the body or allergy to gadolinium, not iodine. But iodine allergy is important for skin contrast or cardiac catheterization. Question here, which intervention should the nurse perform when assisting the healthcare provider with removal of a client chest tube? Select all apply. So in this question, we are basically learn some very important information about the chest tube. So we use the chest tube to remove the air from the lungs. When air inside the pleural space, we call pneumothorax. We use the chest tube to remove the fluid from pleural space. When fluid or blood inside the lungs, we call hemothorax. If both blood and air both inside the pleural space, we call hemopneumothorax. So if our patient have a pneumothorax, if our patient have a hemothorax or hemopneumothorax, we use the chest tube to remove the air, to remove the fluid, or both. Chest tube we also use to re-expand the lungs. So what we have to do, right? Ensure the client is given an analgesic 30 to 60 minutes before the removal. Yes, we give them pain medication before remove the chest tube. Instruct the client to breathe in, hold, and bear down while the tube is being removed. So Valsalva maneuver, we have to educate them to do this, to follow this during remove the chest tube. Place the client in Tendelbar posture. Basically, we tell the patient to semi-polar position, not a Tendelbar. Prepare the sterile, airtight petroleum jelly gauze dressing. So we do not know if any accident is occurred, we will be prepared with a sterile petroleum jelly. So if anything happen, we can put it up there. Provide the healthcare provider with a sterile suture removal equipment. Makes sense, right? So we will be prepared with it. So now here, they said the chest tube is removed when the dressing is minimal or absent, right? If there are no dress secretion, and if the total drainage is minimum or absence, we do not need it there, we have to remove it. Or no air leak. So the lungs is re-expand well. The general steps of chest tube removal, what should we do, right? What are the nursing procedure? What are the nursing care of this? So when time will come to remove the chest tube, the first priority assessment the client for respiratory distress. And also we have to check the breathing sound and also check the vital sign. Means my patient stable or not. So also it is important everybody know that chest tube should be placed below the chest level. Very important. NCLEX would ask. And if your patient under the chest tube, daily X-ray are needed to check the fluid level or to check the air level. The client will have occlusive dressing at insertion site and never clamp the chest tube without healthcare provider order. It is very important when a patient under the chest tube, we need three things beside patient bed. One is occlusive dressing, one is clamp, and sterile water. Let me read from here. Pre-medicate the client with analgesic just before the remove the chest tube, like IV opioid, non-steroidal anti-inflammatory drugs like ketorolac, 30 to 60 minutes before the procedure to promote the comfort. Provide the healthcare provider with a sterile suture removal equipment and also instruct the client or Valsalva maneuver. Apply the sterile, airtight occlusive dressing to the chest tube side immediately. This will prevent air from entering the pleural space. Also, perform the chest X-ray within 2 to 24 hours after chest tube removal as a post-procedure pneumothorax, or fluid accumulate usually develop within this time frame, pneumothorax or hydrothorax or hemopneumothorax. What the education objectives? Before chest tube removal, the client is giving analgesic or pain medication, then asks to perform Valsalva maneuver during the procedure. The nurse should also bring sterile suture removal equipment and sterile airtight occlusive dressing. Also, post-procedure chest X-ray we have to do within 2 to 24 hours. This is very important about the chest tube.